Hello everyone. In this video I'm going to talk about the second section of pharmacokinetics assessment and clinical practice. Okay. As you know, by the end of this series you'll be able to discuss the clinical relevance of pharmacokinetic parameters and concepts, apply the basic principles in therapy assessments, and discuss the concepts and rationale of therapeutic drug monitoring. So this section is about approach to therapeutic drug monitoring. We'll have some definitions, rationale and potential usefulness, and approach to TDM. Okay, therapeutic drug monitoring. Okay, what's TDM? TDM is the process of applying pharmacokinetic principles and knowledge of drug concentration, along with clinical assessment, to facilitate appropriate dosing of drugs in order to maximize efficacy and minimize adverse drug reactions. So the definition had three components, right? Applying pharmacokinetic principles, right? Knowledge of drug concentration, and clinical assessment. And clinical assessment is the most important part in this process. We look at the patients, not at the numbers, okay? So let's start with this exercise, okay? You are the pharmacist in charge of the drug information center at a local hospital. The lab service manager contacted you to ask for your help. They are preparing a list of drug levels that might be needed for therapeutic drug monitoring. A preliminary list has been developed and he asked you to review it. So he has a list of drugs and wanted to know if we need to do TDM for all these drugs. Okay, so in which of the following drugs TDM would be useful? Okay, starting with vancomycin, aminoglycosides, ciprofloxacin until vigabatrin. Okay, what I can ask you now is you can pause the video and think about it. Do you need TDM for vancomycin? Do we need TDM for aminoglycosides and so on? Okay, and I'm going to talk about those in later slides. Okay, so I'll come back to that exercise later. So what's the rationale for therapeutic drug monitoring? Is to improve the patient outcome by increasing the efficacy and minimizing toxicity, right? This is what we need, right? So, and it's generally, therapeutic drug monitor is useful in those drugs with narrow therapeutic range, whose efficacy and toxicity are proportional to drug concentration. So I said three things here. So drugs with narrow therapeutic range. Narrow therapeutic range, so the efficacy and toxicity levels has an efficacy concentration and toxicity concentration, right? So this is the minimal effective concentration, and this is the toxicity level. And this efficacy and toxicity also should be proportional to the drug concentration, okay? Not just a concentration. And with narrow therapeutic range and narrow reference range, this means like increasing the dose a little bit might increase the concentration to the toxic level, and so on, okay? So this is some of the rationales of therapeutic drug monitoring. Number one, drugs with well-established references. So as we mentioned, drugs with well-established reference range are drugs that where TDM could be useful, right? Examples of those drugs include PHENYTOIN and VANCOMYCIN. Okay. Also, TDM is useful on those drugs when the drug response cannot be assessed directly, and at the same time there is a good correlation between drug concentration and response. Again, anti-seizure drugs like PHENYTOIN. So when the patient takes a medication or anti-rejection drug, and sometimes like we are dosing the patient, but we don't know if the dose is sufficient or not. Like, so for seizures, We'll wait until the patient gets a seizure, but if the patient is under seizure control, what is the concentration sufficient or is still at risk for seizures? Drugs with narrow therapeutic window, as I mentioned, drugs with unpredictable pharmacokinetics. What does this mean? TDM is very useful in drugs with unpredictable pharmacokinetics. In those drugs, administering the same dose to different individuals could yield different response and drug concentrations. So drugs with highly variable pharmacokinetics, like for example, TACROLIMUS, an anti-rejection agent, when you give the same dose at highly variable concentrations between patients. Also drugs with nonlinear pharmacokinetics, like PHENYTOIN and voriconazole, increasing the dose, proportional increase of dose is not associated with proportional increase of concentrations. There are many examples like that. The absorption, distribution, and disposition processes mentioned earlier could be saturable in some drugs. So absorption, distribution, and metabolism could be saturable, leading to the nonlinear, unpredictable pharmacokinetics. If you see in this graph, this shows a plot of the dose versus the AUC. For most drugs, the relation between the dose and AUC, the area under the concentration time curve, is linear, right? The higher the dose, the higher the concentration, the higher the AUC. However, some drugs have saturable metabolism, like PHENYTOIN, for example, and voriconazole, follows they have saturable metabolism and follow Michaelis-Menten kinetics. So this means like proportional increase of dose is not associated with proportional increase of concentrations. And see, like the concentration, instead of being linear, it goes up like that. So we need to be very cautious when increasing the dose, right? The other one too is drugs with saturable protein bindings or autoinduction of their own metabolism. Examples of those, VALPROIC acid has saturable protein binding. What does this mean? The protein binding gets saturated. So when you give VALPROIC acid, the higher the concentration, the higher the free fraction. And it give you less than proportional increase of the concentration. Okay? Carbamazepine, it actually induces its own metabolism. And the higher the concentration, the faster the elimination. As you can see here, less than proportional increase of concentrations. So these drugs with unpredictable pharmacokinetics, I think it's reasonable to use TDM for those drugs. Okay. Okay. So we said drugs with well-established reference range cannot be assessed directly. The drug response, drugs with narrow therapeutic window, unpredictable pharmacokinetics, and also other factor rationale is suspected toxicity. So some drugs has concentration dependent adverse reactions. As you can see here in this table, here PHENYTOIN, VANCOMYCIN, lithium, until voriconazole, many drugs has concentration dependent toxicity. This table shows several examples of those drugs that exhibit concentration-dependent adverse reactions, like PHENYTOIN, vancomycin, lithium, and so on. So, if we are suspecting toxicity, let's say the patient was on digoxin or tacrolimus, and you're suspecting signs and symptoms of toxicity, like the patient developed nephrotoxicity from tacrolimus, and this is a renal kidney transplant patient. So, if you see a nephrotoxicity, is it like due to tacrolimus toxicity or due to suboptimal immunosuppression? How are we going to answer this question? Measure tacrolimus level. If it's high, this means toxicity. If it's actually very low, this could be graft rejection, right? Like the lack of efficacy of tacrolimus. So suspected toxicities could be helpful. Other factors, adherence consult. So TDM is also useful when we need to check for adherence or compliance, right? We could measure drug levels to check if the patient is taking the medication correctly. There is no drug interaction, for example, at the absorption, and so on. When there is no physiological parameter available to check for adherence. TDM also useful in when there is an unpredictable drug interactions. There are some drug interactions are very complicated, and in order to figure out how these interactions are affecting the patient therapy, we need to do TDM. I'll give you examples. I have 2 examples for you here: phenytoin and valproic acid. This graph shows the changes in the pharmacokinetic parameters of phenytoin when valproic acid is added. Okay, so this is a time 0 patient on phenytoin, and these are pharmacokinetic parameters. You don't have to focus on these numbers, on these values, on these parameters, but I want you to see something here. So when valproic acid is added, initially valproic acid is highly protein bound. It will displace phenytoin from protein binding, and the free fraction will increase, and this might affect the clearance and the volume distribution. Okay. However, later on, valproic acid will inhibit the metabolism of phenytoin, and this will affect the clearance and so on, and will result in multiple changes in the phenytoin pharmacokinetic parameters. So this is a very complex interaction. How can we deal with this complex interaction? Simple. Actually, therapeutic drug monitoring. If the free fraction of phenytoin, free concentration is available, you can measure that, and you will be able to fix this interaction. Another interaction is tacrolimus and clarithromycin. Clarithromycin, which is one of the most commonly used prescribed antibiotics in community. It's actually very strong. It's a strong liver microsomal enzyme inhibitor, and it actually could inhibit the metabolism of tacrolimus. It interferes with tacrolimus metabolism, leading to a significant increase in TAC concentration, which could lead to tacrolimus toxicity, like nephrotoxicity in renal transplant patients. As you can see in this graph here, so this is the low concentration, okay? So this is tacrolimus with no clarithromycin. And this one is tacrolimus with clarithromycin given with 7 days post-clarithromycin. Concentration is significantly increased. And if you look here, like in a patient, tacrolimus concentration here actually parallels serum creatinine. So the higher concentration reflects nephrotoxicity, and the TAC level goes down, serum creatinine goes down. So how can we deal with this interaction? Okay, do we need to add, like for one of the questions, if this interaction exists, do we need to use clarithromycin? Can we use another antimicrobial? If not, very close monitoring and significant dose reduction of tacrolimus is needed. Okay. Other rationale is disease-related altered pharmacokinetics. Okay, we can also use TDM when there is disease or a condition leads to alteration of the pharmacokinetics, such as in patients with liver, kidney dysfunction, pregnant women, in older adults. TDM could be useful in those situations. I'll give you an example here, like vancomycin, gentamicin, digoxin, lithium. These are the half-lives in patients with normal kidney function. And these are the half-lives in patients with renal failure. You see, like vancomycin, for example, the half-life is 7 to 9 hours, but in patients with renal failure, the half-life could go up to 140 hours. Gentamicin from 2 to 4 hours up to 70 hours. So this makes the use of TDM useful in those situations, right? Because it's unpredictable. We don't know what would be the half-life, so you need to do therapeutic drug monitorings. So in the previous slides, we focus on why do you do TDM? But the question is, why we don't need to do TDM, right? For example, in drugs with predictable pharmacokinetics, like the dose is linear with the concentration, right? And there's minor drug interactions, so there is no need to do that. when the pharmacological response is not correlated with drug concentration. Like, for example, Plavix or clopidogrel. Clopidogrel, gets metabolized into an active metabolite, but it gets eliminated right away. However, the effect on the platelet function goes beyond the concentration in the blood. So when you measure the concentration, it might not reflect the platelet function. Same with aspirin. When the pharmacological response can be easily measured. So, for example, antihypertensive agents, you can measure the pharmacological response, like measuring the blood pressure. In drugs with wide therapeutic range, like this means like very well-known safety margin. So the higher the doses, there's no concentration, there is no toxicity, right? Like, for example, of ampicillin. So here's, as you can see here in this graph, the antiplatelet effect. This is clopidogrel metabolite concentration, goes up and down quickly. However, the antiplatelet effect stays longer. So if you measure a concentration here, this concentration does not reflect the platelet function, right? The antiplatelet function. So measuring the antiplatelet function in this situation could be better than measuring the concentration of clopidogrel or its metabolite. So let's back to the exercise that I just mentioned in the previous, earlier in the lecture. You are the pharmacist in charge of drug information centers, right? And the lab manager wanted to ask you if therapeutic drug monitoring is needed for those drugs, right? Okay, so let's go over one by one. Vancomycin. Vancomycin trough level, it's a good surrogate for AUC above minimum inhibitory concentration. And it's a time-dependent killer and has wide interpatient variability, so TDMs could be useful. For aminoglycosides, aminoglycoside usually has nephrotoxicity and ototoxicity, right? And this toxicity really is more dependent on the duration rather than the concentration, but adjusting the concentration actually could maximize efficacy and minimize toxicity, so TDM is useful. Ciprofloxacin is a concentration-dependent killer, and also Cmax above MIC could be useful for efficacy marker. However, we can use higher dose and it could be found safe. So TDM might not be useful here. But TDM, like there's some reports are saying TDM of ciprofloxacin could be useful in obese individuals. So I'm going to cross that. Ampicillin has a wide therapeutic range. Higher IV doses could be used. And so TDM is not useful. Phenitoin as nonlinear kinetics, as I talked about. Carbamazepine could be unpredictable kinetics. I don't usually use it. It induces, I don't usually use TDM for carbamazepine unless like I'm suspecting toxicity or lack of efficacy. However, it induces its own metabolism. Also, concentration could be unpredictable. So yes. Lacosamide, I don't need to do TDM for it because it has linear kinetics and anti-epileptic drugs and predictable concentrations. Valproic acid, SATURABLE protein binding, right? And if you are suspecting toxicity, so we can measure valproic acid concentration. We can do TDM. Levetiracetam has minimal drug interactions, predictable kinetics, so TDM might not be useful for most patients, but it could be useful for special population, also with lacosamide. Tacrolimus has a wide intersubject variability, narrow therapeutic margin, toxicity-dependent concentrations, right? It's important to know what could be the anti-rejection concentration, right? Anti-rejection medication concentration. So tacrolimus is very useful. TDM is very useful for tacrolimus. Voriconazole could be useful as well due to nonlinear kinetics. Digoxin also, there has a concentration-dependent adverse reaction score. TDM might be useful. But when you look at the valsartan and amlodipine, You can measure the drug concentration, the blood pressure so easily. So why do valsartan and amlodipine concentration? So TDM is not useful here. Lithium has concentration-dependent adverse reactions. Yes, it's useful. Theophylline, the same. If you look at the clopidogrel, as I just mentioned, measuring the concentration is not correlated with efficacy, so it's not useful. Also with vigabatrin, measuring the concentration of vigabatrin is not correlated with efficacy, so they are out. Okay, so this is the answer. So TDM could be useful on a wider range of drugs, as you can see in the slide, including antimicrobials, anticonvulsants, immunosuppressives, some cardiovascular drugs, psychotropic drugs, and others. Okay, now let's have an approach to TDM. Okay, now we know the rationale for TDM. Let's see how we do it. First, we have a patient with a diagnosis that needs a drug therapy, right? Second, you need to start the drug therapy. You need to ask yourself if the drug that needs TDM is indicated or a reasonable option. Right? Is there another alternative? So let's say a patient has an infection and you need to start vancomycin. Before jumping into measuring levels and adjusting the dosing, ask yourself, is there an alternative agent that does not need a TDM could be used, right? Okay, let's say you wanted to start it. So what's the dose? You need to start on an appropriate dose, right? And then ask yourself, okay, after I started the drug, is drug level indicated? Okay, you decided that this drug needs to be started. You need now to make sure that it's started at an appropriate dose. Then before you order a level, you need to check if actually the drug level is indicated. You don't have to measure a level just because you can. Okay, so if the level is indicated, measure it. Okay, and then this drug level combined with clinical assessment, you can do the care plan and care for your patients. Okay, but the important thing that you need to think about, you need to know that that drug level is can be used as a tool, not as an ultimate target, and you need to treat the patient, not the level. Okay. What are the indications of drug levels? To check efficacy, or if there's a lack of efficacy, right? If there's a suspected toxicity, if there are other comorbidities, right, like renal failure in renally eliminated drug, adherence concerns, and also if there are complicated drug interactions, as I mentioned, right? Now we want to measure the level. When do you need to measure it, right? Do you want to measure it after 6 hours, 1 day, 1 week, 1 month, PRN? Do you want to measure trough, peak, anytime, 2 hours after? So when do you want to measure it, right? So it all depends on why do we do TDM, right? This depends on the clinical scenario and the drug characteristics. Why do we do TDM? Are we suspecting severe toxicity? Probably you can measure the concentration anytime, right? Or checking if the concentration at target measures, if the concentration within reference range, like for example, anti-rejection agents, right? And also generally, we measure the drugs at steady state, right? So steady state, you need to know the drug half-life, VD, clearance, protein binding, and distribution, right? The kinetic characteristics, but generally it takes 3 to 5 half-life for the drug to reach steady state. Many factors that affect the pharmacokinetic of drugs, concomitant drugs, comorbidities, age, and weight, right? And this might affect when do you need to measure the level, right? If there's a concentration effect toxicity relationship, so for example, for antibiotics, so if it's a time dependent killer or a concentration dependent killer, so what do you need to measure? Do you want to check if the drug is really eliminated only, just to avoid toxicity, like in case of aminoglycoside? Or do you want to check if the drug concentration is above the recommended reference range, like for vancomycin? So all that will determine at what time and when do you need to measure the concentration. Let's have a quick exercise here. You have a 37 male, his weight 70 kilos, height 170 centimeters, serum creatinine, good kidney function, 65, and has a diagnosis A. And the patient is otherwise healthy. Okay? So let's say you want to start vancomycin. Okay, so you opened vancomycin monograph. You found this drug is 90% renally emanated, has negligible liver metabolism, and this is your target, 10 to 20. And this is a VD half-life 8 hours, protein binding 55%, and has an MRSA pneumonia, which is vancomycin is used and indicated for. And this is the dose. Let's say the dose is fine. We wanted to start at 1 gram every 8 hours. Okay, so my question for you, when do you need to measure the trough level? Pre-second dose is every 8 hours, so after 8 hours. Pre-third dose after 16 hours, or pre-fifth dose, or in 1 week. So when you think about it, like if you want to measure a steady state concentration, what would be the best dosing? So probably like 8 hours, 3 to 5 half-lives. So I would say 8 multiplied by 3, 24 hours. So pre-fifth dose or in 1 week could be used. However, I will use pre-fifth dose because we want to make sure. I don't want to wait for 1 week until I find the concentration maybe subtherapeutic, right? So I will do pre-fifth dose. Then after you did the level, the concentration came back, let's say at 5. 50% target. So how are you going to increase the dose? So patient was 1 gram Q8. Are you going to do 2 grams Q8, 1 gram Q12, or 2 grams Q12? Simply, if the drug has linear kinetics, doubling the dose will double the concentration. And so we'll use 1 gram Q8, going to be 2 grams Q8. And the question for you, dose adjustment is expected to be needed in case of renal impairment? Yes, because it's 90% renally emanated, right? Liver impairment? I don't think so. Low albumin? Let's look at the protein binding. I don't think so. So the answer is going to be renal impairment. So here is the answers. You're going to do level pre-fifth dose. You can double the dose because it has linear kinetics, and dose adjustment might be expected in case of renal impairment. Okay, so as a resource for this part of the lecture, you can check chapter 22 in pharmacokinetic assessment in patient assessment clinical pharmacy. It will contain more details about this session. And finally, in conclusion, pharmacokinetics is a valuable tool in medication assessment and making therapy decisions. If used for the right drug, the right time, and when needed, therapeutic drug monitoring will be a powerful tool to optimize medication therapy. Thank you.